So first half of Weaver Chapter 7, non-infectious erythemas. I'm leaving out some of the entities like parapsoriasis that don't really have specific histology, and there's some variants of psoriasis, like psoriasis associated with AIDS that they talk about, and I'm just going to go over histologic variants of psoriasis. I put this talk together today so the differential diagnoses are not exhaustive or anything, and you can always go read about that kind of thing on your own as well. And so, like I said, we're going to finish with some unknowns too, so we'll try to keep it moving. So I'm going to record the lectures, and then we're going to post them on the website as a private YouTube video. So Ethan, our IT guy, will keep everybody posted about that. Okay, so the first entity in the chapter is urticaria, and we've got 2 slides in our. We're slowly collecting the slides, so I don't have slides on everything, but I'm going to show you slides we do have, and then I just pulled some photos off the web for other entities. So here is a typical biopsy we get of urticaria at low power. You can see that there isn't a whole lot going on, and it almost looks like normal skin. There's not much going on in the stratum corneum, nothing in the epidermis. But then if you look a little bit more carefully, you've got a very sparse perivascular and interstitial infiltrate. Another thing typical of urticaria, you have these, and you don't always have this, but it's occluded urticaria is lots of neutrophils in the vessels. And then you can see in the background, here, let's look around at the cells. We've got some, that's probably an eosinophil. We've got some neutrophils, probably some lymphocytes. We probably have some mast cells in here, but that doesn't make it mastocytosis. And then you can see lots of spaces between the collagen. So this is edema. And then here I have another nice example. Another urticaria, and you can see this one, similar to the last one, it's got some edema, that separation of the collagen bundles, no epidermal or stratum corneum change, and then the eosinophils really pop out in this one. Eosinophils, neutrophils, got the neutrophils in the vessels. So this is really textbook urticaria. As you know already, there's an urticaria divided up into, and Lieber talks about this, acute, chronic, and angioedema as being in the urticaria category. With angioedema, you get subacute edema. You might or might not have the urticarial wheals, and it tends to be chronic if you do. And then I don't have a slide of angioedema, but because usually it's not biopsied, the infiltrate that we see in the dermis will extend into the subacute. And some things you might need to know for boards, that urticaria can be part of some hereditary diseases, Muckle-Wells, Schnitzler syndrome. There's a hereditary variant of angioedema. Histology really is similar in all of these diseases, except for that subacute infiltrating angioedema. And actually, interestingly, in hereditary angioedema, you're not supposed to have any inflammation, just the edema. Okay, so we just went over that. And then here's just a nice kind of slide I found on the web about angioedema. This is what it looks like with the urticarial lesions and the angioedema. And then in this chapter in this category of urticaria, I wanted to go over urticarial vasculitis, which Lieber does talk about. These are recurrent lesions lasting more than 24 hours. They burn, sting, they can leave hyperpigmentation, often with arthralgias, abdominal pain, really, glomerular nephritis, obstructive pulmonary disease. 30% are hypocomplementemic, and if they are, they have organ involvement. Many are idiopathic, but then many are associated with some kind of systemic disease or drugs or infection. So when you send a biopsy in for urticarial vasculitis, as a dermatopathologist, I look for leukocytoclastic vasculitis, and I'll report whether I see that or not. The term urticarial vasculitis I don't know if any of you have found it confusing, but I have found it confusing over my career. It's probably not a real entity. I mean, it's a clinical entity, but it's probably somewhat of a wastebasket. It's probably some of them are early leukocyte-plastic vasculitis, but others are probably this newly described in the last few years neutrophilic urticarial dermatitis, or NUD for short. It's probably an autoinflammatory disease and has a strong association with autoimmune disease, specifically Schnitzler syndrome, adult onset Still's, lupus, and the hereditary autoinflammatory fever syndromes. I know that we have some cases that would be good for NUD in our files, but that's the kind of thing that you don't put in your line diagnosis, so I had a hard time searching for that. So I pulled this image off the web. This is what you would see in a biopsy of NUD. It kind of looks like urticaria. You don't have any leukocyte-plastic vasculitis. You've got this edema, and then you've got this polymorphous infiltrate, a lot of neutrophils, and you can see here little tiny bits of nuclei scattered around. So that's leukocytoclasis. So we have leukocytoclasis, but no leukocyte-plastic vasculitis. And this is typical of this entity NUD. So I just wanted to mention that because it's a pretty cool new entity. In the urticarial category in liver, they also talk about PUP, or pruritic urticarial papules of pregnancy. A lot of people are moving to this polymorphic eruption of pregnancy term now, but I think it's kind of hard to get rid of this cool acronym, PUP. The histology is nonspecific. It's urticarial-like we've seen in the last few biopsies. You can have some spongiosis. It's usually a clinical diagnosis that's not biopsied. And why would you biopsy? To rule out herpes gestationis. Although HG usually occurs earlier in pregnancy, it can occur a little later and have some overlap clinically with PUP. And it can have some histologic overlap also. So if you suspect it clinically, you need to do a diff to rule out HG. And here is an example of HG. As you know, it likes the umbilicus. And here's the diff. It looks just like bullous pemphigoid or EBA, this linear deposition. It's a beautiful example of IgG and C3. And you know what? Does everybody, does everybody hear me? Uh-oh. Oh, good. Okay, good. Any questions on any of that before we move on to the next? Okay, so, hey, Sylvan. All right.
Hi.
Okay, so let's go on to erythema annulare centrifugum, or EAC, we like to call it. And we had a case from our files here. It's a hypersensitivity reaction, polycyclic with erythema with trailing scale. There are superficial and deep variants histologically. Let's look at our case, which is a superficial variant. This clinically was EAC. And you can see here, there's a tiny bit of spongiosis maybe here. We've got some scattered lymphocytes into the epidermis, not a whole lot though. This, you can interpret this as vacuolar change, but this is really early spongiosis or pseudo-vacuolar change. And then the infiltrate, if you look at it at lower power, it's kind of strikingly perivascular and has this, what we call a coat sleeve appearance. The lymphocytes are really hugging the vessels. And so that's really characteristic of diarrhea erythema, EAC. And in the deep variant, what you get is, you get this, but down here as well. And I have an image to show you that. So the infiltrate is usually mostly lymphocytic, but it can have some eosinophils. There are often some extrapocytic red blood cells, like we see here, these little refractory guys. The differential diagnosis. Oh, here's the, let's go over the deep variant. Here, this is really striking at low power, this coat sleeving. Really beautiful example. Here in this. The histologic differential diagnosis for the superficial variant is drug. Since often there's a little bit of spongiosis, other spongiotic dermatitis, the common ones, winter contact, et cetera, et cetera. The deep variant, you think about all the diagnoses that begin with L's because it's a superficial and deep lymphocytic infiltrate. So, but mainly you would want to think about syphilis, lupus. You might think about erythema migrans, Lyme disease, drug eruption for sure. Any questions about that? Oh, I don't have a slide for erythema gyratum repens, but I had to put, just for fun, an example of the clinical, and it has this wood grain appearance. This is also, I think of it as a gyrate erythema. The histology is not as specific as EAC, unlike the clinical, which is a lot more striking. They say, and I've actually never seen a biopsy, it's so rare. And I think when you see it, you probably don't biopsy it. But you can get a little spongiosis, sometimes you have eosinophil neutrophils, sometimes you can have that EAC-like deep coat sleeving component. As we know, 82% of cases are associated with internal malignancy, especially the lung, esophagus, breast. Anybody seen a case of that? We had a case in Oregon here, I guess it's been about 7 or 8 years that came to our Oregon Dermatologic Society. It was really
Yeah, I've never seen one.
Yeah, I mean, they didn't have to biopsy it, right?
Yeah.
So, all right, so the next case, we're going to dive into erythema dyschromicum perstans, which is another thing we don't actually see very much in Oregon because it really occurs in darker skinned patients. You probably see it in other parts of the country more. I know that when I lived in Albuquerque, I saw it more. And you get the disseminated macules that coalesce into large polycyclic patches, this gray hue, and the histology is not specific, but it is characteristic in this clinical context, and that is you get this very subtle, this is early, if you biopsy it early, but this very subtle vacuolar interface with a few necrotic keratinocytes here. You can see kind of this guy's not looking so happy. This guy, maybe that's a necrotic keratinocyte. And then you get this really prominent pigment incontinence, and that's what's giving you that blue appearance histologically. You're getting that Tyndall effect from this pigment in the dermis. So early, and it's rarely biopsied early. I feel like every time I get a biopsy that says rheumatoid ashy dermatosis, it's just in its late stage, and all I see are the melanophages. Often don't get that subtle lichenoid interface of the early phase of EDP. The histologic differential, you might think about drug or fixed drug eruption, especially with that prominent pigment incontinence. Do you see that up here? Maybe in Salem you might see more down in the valley, more ashy dermatosis. Nobody, huh? Okay, let's move on to Rigo. Leaper splits it out into the simplex, nodularis, and LSE. I kind of think about this as one big spectrum. And when we see it on biopsy, it's almost always a prurigo nodule or LSE. Let's pull up our case that we have. Oops. I have to 2G. We see this almost every day in our practice. So here it is. This dermatologist did a really nice shave biopsy, and you can see, let's see if there are any hair follicles in here. This might be might be an altered hair follicle, but this histology is what Ackerman called the hairy palm sign, and that is, this is what looks like acral skin, but it's not. So you get this massive hyperkeratosis, mostly made of compact orthokeratosis. We get some hyperkeratosis, this marked epidermal acanthosis, you might even call it psoriasiform. And then you get these very characteristic vertically oriented vessels in the dermis, and a little bit of fibrotic stroma. And this is all this gray stuff is solar elastosis. This is on really badly sun-damaged skin. And you can see this fibrosis is kind of pushing it down. So we call it LSC when there's no ulceration, prurigo nodularis when there is ulceration. That's a little bit artificial in a way because really that's a clinical descriptor. They talked about it, OHSU ran rounds a few weeks ago, that this may be a form of atopic dermatitis. I'm not quite, I think Solveig, you're probably there. The simplex histology can certainly have some spongiosis in it, and although it can clinically mimic DH and can be grouped papules, there will be no papillary dermal neutrophilic abscesses. Just a little sponge and maybe some eosinophils, not a lot. And then the nodularis LSC histology, we just went over that hairy palm sign. And in the late stages, it may have really, really marked epidermal hyperplasia to the point of you wonder about a keratoacanthum. Okay. So let's go on to psoriasis. Anybody have any comments about prurigo? So I'm mainly going to talk about the histologic patterns. Let me bring up our cases we have in our files. No cases again. Oh. 2H2. Well, let me double check my number. Sorry about that. Oh, it's 2H. I think it's an RSS case. Little mistake there. 254. Okay. So we've got several examples here of psoriasis. This is all of these are really beautiful examples. I think we get really excited when we see a classic example because so many times the clinician is biopsying to distinguish between a chronic eczematous dermatitis and psoriasis, and then we actually have a really hard time deciding ourselves on histology. So when I get a really nice psoriasis, I'm like, oh my God, I'm going to put it in the study set. So this is psoriasis vulgaris, and it has all the features that you want to see for the diagnosis. And the first thing at low power is you see this very characteristic hyperkeratosis with this lifting off of the stratum corneum, kind of like it's taking off like an airplane off the surface of the biopsy. And then when you look a little bit closer, we have what we call dry scale. Those silver scales you see clinically is this a dry scale, which means there's no serum in it. And it's loaded with neutrophils in this particular case. And then here, just sitting on top of the epidermis, is a Monroe microabscess, excuse me, and that's this collection of neutrophils sitting right here. When there's a lot of spongiosis with it, and I think these two particular lesions are on a spectrum, but you could call it a spongiform pustule of I don't know, Kajo. I don't know how to pronounce it. Does anybody know? Want to pipe in? I only ever read that word. So, so spongiform pustulation, neutrophilic microabscess formation, and then what you have in the epidermis is these elongated reedy that are fusing, kind of bulb-shaped, kind of, heavy at the bottom. And then the suprapapillary plates are very thin in comparison to how long these reedy are. And then the other thing that you get is these dilated vessels touching the underside of the epidermis and a loss of the granular layer. This combination here, the neutrophils, the loss of the granular layer, the dilated vessels, that is all diagnostic of psoriasis. And this is what contributes to the Auspitz sign. When you take off the skin, you get the punctate bleeding, these little capillaries that are getting unroofed. So when you look in the dermis psoriasis, it's almost almost all lymphocytes. You will occasionally see an eosinophil. If you see a lot of eosinophils, you might wonder about a superimposed allergic contact due to treatment. There are certain variants of psoriasis may have eosinophils more frequently, such as guttate psoriasis, and we'll look at that next. And I'm always impressed, like one of the things that I think about when I look at a biopsy of psoriasis and know it's psoriasis from low power is there isn't that much inflammation compared to how much epidermal change there is, which is a contrast to a subacute spongiatic dermatitis. Usually there's a lot more inflammation when you have this much epidermal change. And here's some other examples of psoriasis. This psoriasiform epidermal hyperplasia, you can draw a line here. The bottom of it's so regular. Even more. This one's maybe not as impressive, but see, it's got that stratum corneum lifting off the surface of the epidermis. And then it's got that diminution of the granular layer. Sometimes it's really hard to find the neutrophils. There may be one or two in here. Sometimes I have to do level sections to find them. Here we go. Here's a nice selection. Okay, so let's move on to other variants of psoriasis. I do want to point out that psoriasis, Ackerman has a great book. It's out of published, he's dead now, and it's also out of publication, but it's called Lives of Lesions, and psoriasis is kind of the prototype for that. So when you look at one of these plaques, you want to biopsy one of the early papules at the edge. That's where you're going to get your Monroe microabscesses and spongiform pustules that are really diagnostic. Later, as the plaque gets older, you're going to have less of this, and it's going to be more difficult to make the diagnosis. These are really the things you want to see to make the diagnosis. You want to always do a PAS stain to rule out tinea because it can perfectly mimic psoriasis. Impetiginary subacute spongiatic dermatitis can also mimic psoriasis. You got neutrophils, but usually have a lot of serum also in the stratum corneum. And then oftentimes you can see the bacterial colonies. And then very late psoriasis can look a lot like LC. Here's a guttate psoriasis, as you all know, associated with infection with group A beta hemolytic strep. It may resolve or it may develop into chronic psoriasis. It has an acute or early psoriasis histology and often even has spongiosis and eosinophils. So let's look at our example. We have 2H5. And I would say we see this fairly frequently. It's not unusual to get a biopsy of guttate psoriasis on any given day. And you can see here, this is really acute. It doesn't have that hyperkeratosis of psoriasis vulgaris. It's got a normal basket weave stratum corneum overlying the collections of neutrophils. It doesn't have that marked psoriasiform epidermal hyperplasia. It can have a little bit of sponge. It can have some eosinophils, and you can see this is an eosinophil. Often has a little purpura, some extravasated red blood cells, but for the most part, it's lymphocytes. Here's some more examples. And you can see this basket we stratum corium. See, this hyperparakeratosis is starting to come up. It's got the neutrophils. It's got the loss of the granular layer, the dilated vessels. So this is turning into more of a psoriasis vulgaris plaque kind of lesion. This one more. Similar to the last one, nicely coming up. Cute. Okay. Anybody have any questions on psoriasis?
Hi, Jessica. Can you hear me? It's Brian.
Yeah, I can hear you. Hi.
Yeah, so just one interesting thing we've noticed the last couple of years with the biologics, one of the side effects of the biologics is a psoriasiform rash, and it looks just like psoriasis. So we get these cases in a psoriatic patient on, a biologic now with a rash, and there you get the histology looks like perfect psoriasis, and it's tricky to find out.
Yeah, exactly. I totally agree. I feel like we're often not helpful in that situation. Yeah. Unless it's, obviously some kind of drug with lots and lots of eosinophils and some kind of mixed histologic pattern. Yeah, I agree. Oh, I'm sorry. There's one more psoriasis pattern I wanted to go over, and that was pustular psoriasis. As you know, it can be generalized or localized. Clinically, pretty much has the same histology when we're looking at it under our microscopes or on our Philips digital scanners now. And so let's bring up that case, H3. This is something we don't see that often. And we can see, actually, this is an acral site. This is acral type stratum corium. And you can see at low power, it's got that same kind of, the normal stratum corium is being lifted off by this thick parakeratotic layer. And actually, in this particular example, there is some serum. So occasionally you can get serum. And then here we've got this nice spongiform pustule. You can see how it's so large on this, look at here. So large on this slide, you can see how this was seen clinically. All right, pustular psoriasis. Okay, I'm doing pretty well, 435. Anybody have any comments on pustular psoriasis? Once again, do your PAS stain if you're reading your own slides and you see that. You want to make sure you don't miss tinea. All right, that leaves us with our last entity in this first half of the chapter, which is pityriasis rosea. We've all seen it, the Christmas tree pattern clinically. And what we see histologically is what we call pityriaciform spongiosis. I'm going to show you that now. This was actually Brian's case recently. This is a harrow patch. Oops. Just double check my. Oh. It's 2K. So you can see at low power, that looks like a spongiotic dermatitis with this little bit of sponge here. Let's start at the top with the stratum corium. Can everybody appreciate that there are these little mounds of parakeratosis? There's one over here. There's one coming up here, not the greatest. This is really the best right here. I think we can. There's maybe one here at the edge. And then there's definitely spongiosis. That's where you get a cute sponge. And what you have in pityriasis form of spongiosis is you have this mound of parakeratosis over spongiosis. And then what you have in the dermis is you'll have a predominantly lymphocytic perivascular infiltrate with some purpura. And let's see if you can see some of these refractile red things are not collagen, they're extravasated red blood cells. In its late stages, you can have eosinophils. Not a lot of them, there are usually just a few of them scattered around. So unless you have the clinical history, you might think of PR with this mound. You might suggest it to the clinician if they weren't thinking about it. But there are other entities that could have this histologic appearance. And that differential is the leading edge of erythema annulare centrifugae, which we went over earlier. Pityriasis rosea-like drug, and then the usual spongiotic suspects, atopic, contact, nemular dermatitis, obviously with this clinical, and then tinea, you always want to do a PAS stain. You see spongiosis and stratum corneum change. Anything else on PR you want to chime in, Brian or Jim? Okay, so let's go to the unknowns. I'm going to start where Brian left off last week. Cases. And you guys probably didn't get the heads up on these, so we'll just we'll just struggle through them together here. Okay, number 101. Okay, now I want everybody to try to enter a diagnosis in before I give my diagnosis. I will tell you, this is the axilla of a young person. Pretty much a low power diagnosis. Oh, let's go back. Let's go back to one question about early edema, spongiotic lesions, versus early interface. For early interface, you really want to hold out for necrotic keratinocytes for an early interface. So if you look and there's vacuolar change and there are no necrotic keratinocytes, don't call it an interface. You really have to have some cell death at the DEJ for that. Yeah. Okay, so axilla of a young person. Look a little closer here. It's melanocytic, I think everybody can agree. Anybody? No one wants to commit themselves. Okay, I was told at UCSF, nobody gets to answer until everyone's typed in their guess. So, yes, compound nevus. Yes, this is it. This is a compound nevus, and it's in the axilla. So we consider a special site. So there's some features. I wouldn't say this is like the greatest example of a special site nevus. It isn't a special site, but special site nevi, axilla, scalp, ear, breast. They tend to have nests of melanocytes. They're a little bit bigger than normal, so you might get a little bit alarmed. Sometimes these cells have a little bit more cytoplasm, so you might get a little bit alarmed. And then they're often this kind of bridging of reedy-binous melanocytes like we see here. So kind of a lentiginous growth pattern, this bridging of reedy here. But unlike melanoma, you can see that this is all nested at the epidermal junction. If you look closely at the cells, they have really banal nuclei. They're very monotonous looking for the most part, ovoid nuclei, small nucleoli. You can look at the size of the melanocytic nucleus compared to the keratinocyte nucleus. It's not that much different or much bigger. You will occasionally get maybe like one big melanocyte, but for the most part, very monotonous and banal. This one has a lot of melanophages, so it might look funny clinically, excuse me. Okay, and you might even call this congenital pattern because you see here we don't have a hair follicle or an eccrine gland here, but this is diving kind of deep, and it's an in-person probably. Okay, so let's go to the next one. This is similar but different. Let's look at the surface here first. Anybody want to hazard a guess? I've got these almost verrucous projections. Yes, molluscum. Fantastic. This is low power diagnosis. It looks like a verruca almost with this kind of cup-shaped architecture. Hypergranulosis in a way. And then there are these intranuclear inclusions that are pushing the nucleus to the side of the cell. I'm sorry, I believe they're cytoplasmic inclusions, pushing the nucleus to the side of the cell. So this is molluscum. And just like imprint this on your brain, this is molluscum. That's exactly what it looks like. And then down here in the dermis, what do we have? Yes, nevus, exactly. Yeah, very nice. So they twofer, that's what we say. Okay, let's go to the next one. So at low power, we can see there are these big globules of what? What are these? Anybody? Yeah, looks like sebaceous hyperplasia. Yes, looks like sebaceous hyperplasia, but this is supposed to be a sebaceous adenoma. And the clues to the diagnosis, this is a really well differentiated one because there are not a lot of basaloid cells. Because I think maybe over here you can see there are maybe more basaloid cells than normal around the edge of these lobules. And in addition, these lobules, some of them are entering onto hair follicles, but others kind of look like they're entering directly onto the epidermis. I think that's another clue to this, that this is a neoplastic sebaceous lesion rather than sebaceous hyperplasia. And you can see it has this nice kind of smooth outline at low power. In sebaceous adenoma, you'll have basaloid cells along the inside, which are pseudocytes outside, excuse me, basaloid on the outside, which are pseudocytes on the inside. And you're supposed to have transitional cells in between, which are maybe these guys are kind of half sebaceous, half basaloid. I think you kind of have to use your imaginative scope for that. There's going to be another example here. Let's see this one. And you can see here maybe a little bit, maybe because the stain is a little bit darker. Can you see it? Everybody see there's a little bit, it's a little bit bluer on the edges. Yeah, good question. Kind of similar So the differential is sebaceous hyperplasia. You might also think, if you're thinking about sebaceous neoplasia, a sebaceoma. Sebaceoma has a lot more basaloid cells, and it usually has a kind of mixed up appearance. You see more basaloid cells in here mixed up with the sepocytes. And what do you think about when you see a sebaceous neoplasm, like a sebaceous adenoma or a sebaceoma that's not on the head and neck? Yes, exactly, Meritor, exactly. Or in a person less than 50. Okay. So I went half an hour over the last time I gave this talk, so I'm going to be on time today. All right, so number 4. This is a little tricky. Okay, so actually the key to the diagnosis is not here, but if we just have this, and we said this is an acral site because we don't really have hair follicles or anything, what would this be? We just went over this in our Leaper chapter. LSC, exactly. We've got massive hyperkeratosis made of compact orthokeratosis, this really marked hypergranulosis, marked epidermal hyperplasia. We've got the beautiful vertically oriented vessels in the epidermal papilla. Yeah, exactly. Okay, but that's not what this case is, although it's got a component of LSC. It's got something down here in this other fragment in the biopsy, which looks like soft tissue. It doesn't look like we're in the dermis anymore. We don't really have any adnexal structures. So what if I said we're near a joint? And when you biopsy this, some myxoid material came out. Exactly, digital mucus cyst. It's not really a true cyst with a true epithelial lining. It kind of looks like this might be epithelial lining, but it really isn't. These are really inflammatory cells and fibroblasts. This is degenerating, collagenous and soft tissue. We don't really know what causes these, actually. The digital mucus cyst, yeah. And if we did a mucin stain, we'd probably get a lot of mucin to light up in here. But we don't really need it for the diagnosis. Right. Next one. Right. Okay. This is actually in our chapter from today that I did not cover this. So, normal bascoid stratum corneum. What's going on here? Can anybody tell me what category we're in? Is the dermatitis? Is it spongiotic? Is it lichenoid? Is it psoriasiform? Yeah, exactly, lichenoid. So here, we've got that, I guess you could kind of call it pseudovacuolar change, but then we've got necrotic keratinocytes, and we've got nice colloid bodies, these pink blobs. So, and we call these jagged reedy. So this is a lichen planus pattern with the jagged reedy, and then you have wedge-shaped hypergranulosis. Over here too, wedge-shaped hypergranulosis. Usually not much going on with stratum corneum. Wow, if this is on the scalp, maybe this is lichen planopilaris. We've got a perifollicular scar here. And this is in our study set as lichen planus. Yeah. Other things you might want to think about in the LP like histologic pattern would be lichen planus light drug. Probably not collagen vascular disease. Don't usually have this kind of jagged reading. If it was a single lesion, you would think about lichen planus-like keratosis, of course. And in that event, you would be looking for changes of solar lentigo or seborrheic keratosis on the side of it. This is LP. And for lichen planus-like drug, things that can be helpful to that is often there's parakeratosis, and often there are increased numbers of eosinophils. So, next case. Okay, I'm going to help everybody out and say this is not dermatitis. So we've got a nice big shave biopsy here. And here's the normal epidermis. And here's the lesion. And we can see we've got what we call pallor of the epidermis. And some of these keratinocytes look like they have clear cytoplasm. If we look at the size of the nuclei, they're about the same size as the more normal looking keratinocytes next door. Very good, cell take. A clear cell acanthoma. Yeah. And what they say is usually you have neutrophils percolating through here. I sometimes find it hard to find them, truthfully. Maybe we look really hard. Maybe can't really find them. They're often there, but sometimes they're just not, and they're not required for the diagnosis. Things that you want to think about when you see this epidermal hyperplasia and pallor at low power is there are clear cell variants of Bowen's disease. So you always want to look down at higher power and make sure there's no cytologic atypia of the lesional keratinocytes. Looks like there might be a mitotic figure or two here. Oh yeah, for sure, but that does not make it malignant. And then you might want to think about dermatitis with that kind of pallor. There is a little inflammation. See how well demarcated this is? It really looks like an epidermal neoplasm. Okay. We're doing 455. Okay. 27. We heard everybody liked unknowns, so we're going to do them every Sunday. Okay, here we go. That's actually not the lesion. Here we go. First of all, where are we on the body that we have this skeletal muscle here so close to the dermis? Where could we be? Neck. It could be eyelid for sure. Yes, I like eyelid. Yep, eyelid. Yeah. Okay. So we've got what looks like a tumor at low power. It's very circumscribed. It's got these, almost looks like a keratinous cyst here. The more either duct-like structures or little cysts. Maybe they're ducts. Actually, see here, they have this pink cuticle. I think this is a duct for sure. And over here, a duct. And you can see there's some clefting around the tumor, but it's not really around the nest so much. No. And then in between the nest of this tumor, which by the way, this cells look very bland, there are lots of spindle cells. Lots of spindle cells. It's called a specialized follicular stroma. Does anybody want to guess what this is? It's in the basaloid tumor differential. Cylindroma, that's a good thought, because they do kind of look, yeah, trichoep is the answer. They do kind of look puzzle piece, don't they? Yeah, they kind of do. But but this is a trichoep. Cylindromas tend to be, I would say, Brian and Jim, you can chime in on this, a little bit larger. The nests tend to be a little bit larger. They tend not to have such prominent duct formation. I think we probably see desmotrichoepithelioma, desmoplastic trichoepithelioma, more than we see just in kind of normal trichoepithelioma, which is what this is. SPAP is that's a thought. Syringo cystadenoma papilliferum. Yeah, it would be in the differential diagnosis. That you tend to see in vaginations, in more kind of elongate duct formation, and often lots of plasma cells in the stroma. Yeah, cylindroma has two types. Yeah, this is all one cell type. Yeah. Okay, should we do one more, or should we call it a day? Why don't we do, yeah, let's call it a day. Oh, one more. The next one is a hard one. Okay. I'll do the last, okay, I'll do the next one. All right. Oh gosh. Okay. This slide is a little bit pale. This is kind of tough. I wish that with the stain was a little bit newer, but anyway, we can still appreciate all the features in here. Okay, so would anybody like to describe the reedy ridges here? And what I'm getting at, I guess. Oh, melanoma. Oh, that's a good thought. That's a good thought. Yeah. This does look like a nest for sure. Yeah. And there is some pigment in here. I'm not sure what it is. I think this may just be artifact. But you're right. Look at all these cells with halos around them. They look like melanocytes for sure. But actually, this is a rash. And these are all lymphocytes. And so what is this pattern when we see these lymphocytes, so many of them scattering into the epidermis? All the lymphocytes are these guys with very little cytoplasm, and they have darker nuclei than the neighboring keratinocytes. So they have more condensed chromatin. It's a lymphocyte. So look how many lymphocytes are scattered throughout this epidermis. They're also in the dermis. Yeah, this is mycosis fungoides, and we call this epidermotropism. And the differential is a spongiatic dermatitis. This looks like almost like a Langerhans cell abscess, right? Yeah, my fungusitis, I like. This looks like a spongiatic vesicle for sure. And actually, there are even some Langerhans cells in here. You can see this here. This has this kidney shape. So, back in the old days, we used to say, mycosis fungoides cannot be spongiatic, and mycosis fungoides cannot have Langerhans cell in the vesicles. That they have to be all, the neoplastic T cells. But actually, we of course, when you say something like that, it eventually comes to be not true, and we disproved it. So these are, I'm blanking on the name. Help me out, Brian and Jim. The abscesses and mycosis fungoides are.
Putrias.
Putrias, thank you. I don't think.
Yeah, Jessica. This is also one I look at. I would think, is this something in the pagetoid reticulosis or Wernicke column? If it's a solitary lesion, because it has so much of that, epidermotropism, I'd wonder about that.
Yeah, exactly. Very good. Yeah, if it was a solitary lesion. Yeah. So the pertinent features are, and they've done studies on this. Actually, I would say the #1 feature in this biopsy that helps us to make the diagnosis is the lymphocytes, a very dark nuclei. And I think if the stain was better, they would really pop out as being hyperchromatic, and they have halos around them. And this is, they've done lots and lots and lots of studies on what is the most sensitive histologic feature in mycosis fungoides, and it's the lymphocytes with the halos, aside from the epidermal tropism. So this is a beautiful example, and you can see they really like to hug the basement membrane. They like to line up along the basement membrane here. DEJ, I mean. So here they're lining up like little soldiers. And yeah, and we could do immunostains to show that this is an abnormal T cell population in epidermis. So we don't necessarily have to do that. If we have like a really great mycosis fungoides clinical, if you send in your requisition and you tell me this looks like mycosis fungoides, or you send me a photo, I, with this histology, do not need to do immunostains. So it's a really nice example of PET stage mycosis fungoides. Anybody want to add anything? I feel like we rarely get a roulette MF that looks like this. Usually we're struggling.
It's a great example.
Yeah, it's a great example. It's a very clinical pathologic diagnosis. So if somebody writes roulette mycosis fungoides on their requisition, and please do if you're thinking about it, then I will give you a call before I do anything. It's so clinical pathologic. And you might eventually get this if you follow a patient over many months or years. It might start out to be non-specific histology, a little bit of sponge, a little bit of dark lymphocytes, but not so great. And I have had cases that patients have been biopsied over several years, and they eventually develop this classic PET stage histology appearance. So, yeah. Better to underdiagnose mycosis fungoides in the PET stage than to overdiagnose it. Okay, everybody, thanks for tuning in, and we'll see you next week. It'll be Jessica Ferry.
Thank you.